Perfect. So, first of all, I introduce myself. I'm a neurosurgeon from Italy. I work in this center. It's a big center in the center south of Italy. It's called Neuromed. We have big facilities and mainly elective surgery. Uh, so my story is this one. These are my conflict of interest. I spent skull-based fellowship in the lab with in 2016 with Bernardo and a clinical skull-based fellow in Paris with Sebastian Polish. So my job today is to give you some idea of the importance of training in neurosurgery to shift from from the lab to the OR in a safe way. So, skull-based surgery is definitely all about bone drilling to reach deep located lesion, reducing the impact on the brain, on the brainstem of our maneuvers. Why this is so important? Because the skull-based lesion can arise almost everywhere in the skull base. The conventional approaches that are those that are mainly used are okay for many pathologies using the classic corridors like the one of the rional approach, subtemporal or retrocede approach. But sometimes these corridors can become so narrow and deep, so changing the philosophy and the perspective can make your surgery easier with skull-based approaches. Many approaches are proposed in the literature. Just as important for yourself to have an organization, mental organization. This is the most simple classification from anterolateral to posterior approaches to the craniosacral junction and lateral approaches to the psoas bone, without forgetting the endoscopic and the nasal approaches. So, uh, when a young neurosurgeon look at these conferences with these big lesion complex approaches, he just starts thinking in his mind that this neurosurgeon has a particular talent, a particular precision, some particular characteristic, resiliency, patience, dedication. But it's important to never forget that behind each neurosurgeon that we see during the conferences, during the skull-based courses, has a story, history behind his shoulder of training, important training. So everybody are excited to go directly in real surgery, reading books, looking at these nice conferences, going to attend some courses, 2 or 3 days courses. But this is not what we really need. We really need something more to increase the safety of our patients. So the anatomy is fundamental for this. Why? Because the cadaveric dissection gives you the landmark to perform safely approaches and interpretation of radiological anatomy can lead you to do surgery in a better way. So definitely just reading, publishing, watching the others doing operation is not enough. Sometimes this is the way that in some country people, the neurosurgeon learn, but it is not definitely enough. So what I and what we suggest is to spend time in Scarface lab. This is the lab where I've been trained. I'm not telling nothing special actually. The importance of anatomy with the respect of surgery is known since the Medioeval, Mondino de Lucy, Andrea Vesalio, and with the modern Albert Rosen for the neurosurgery. Not everybody like the training on a cadaver, I have to say, in my personal experience, when I talked with the older neurosurgeon in different departments, many critics, no bleeding from the cadaver, tissue consistency can be different, there's no tumor to remove, but these approaches may be rarely useful. There is some cost logistics that can also be evaluated. So many alternatives came in the modern period. So simulator, virtual reality, 3D printed models, sometimes they have been proposed as cadaveric-free revolution in opposition to cadaver. I definitely don't believe this. I think that those alternatives may arrive together before the cadaver training. Is something propedeutic than the cadaveric training. Why? Because the cadaver is still the best model, the most realistic model for trainees to learn the anatomy and the approaches. The cadaver has unique analogies with the patient. So the cadaver is unforgiven as it is the patient. If you cut a nerve on a cadaver, you will create a corridor that doesn't exist, so you waste your opportunity on the cadaver. If you cut a nerve on a patient, you will have an injury and a post-operative neurological deficit. The same if you push too much on the brain, you will have confusion on the patient, and you will waste your cadaver while you're doing your training. Anatomical variability, definitely. Respect for the cadaver. If you are used to have respect for the cadaver, you increase your respect and your relationship with your patient, and also with the cadaver, you can simulate a little bit the pathos and the surgical stress that you have in real surgery. Why? Because if you have to do a perfect dissection to take a nice picture for a conference, for a paper, you are really stressed a little bit. So you see, you try to gain the perfection of the movement that is the one that you did in surgery. What do we learn during the experience in the cadaver lab? We learn to become confident with the drill, to understand the different types of drills, which drill I have to choose for the specific area where I have to drill compatible with cancerous bone. The size of the drill is really important. And definitely the cadaver lab helps us to become more confident with the regional anatomy, understanding and exploring all the bone structure, major arterial structure, the perforators, really important, the mechanical nerves. We don't have to forget in this modern era where technology are coming more and more, the importance of microneurosurgery. Microneurosurgery you can really learn on the cadaver because still you have the difference of tissue consistency, layers, different layers are many times neurosurgery is all a matter of understanding the differences among the layers and the tissue in the patients among the pathology and the normal tissue. Important is also to understand that the lab and the lab is propedeutic to the UR for the skull base, but when you go to the patient, you want to be realistic and practical. So surgical timing is important and exposure also. So surgery is not an anatomical dissection. So when you shift from the lab to the UR, you want to be aware that you don't have to do the same exposure that you do in the lab. So going back to the what we saw in the previous slide, what we need after this, after a training on a cadaver, interpretation of radiological anatomy, we need to spend also clinical part in skull-base, with skull-base fellowship in high volume centers dedicated to this kind of pathology. And the most is something that I think I can recommend to young colleagues is don't refuse simple cases at the beginning of your career, especially in some specific country like Italy. Don't refuse span surgery because you can learn something and you can start to be more confident with the pathology, with the responsibility that comes dealing with the patients and in the first person as first order. So your journey should be this one coming from the lab to transpose, for example, an anterior cranioidectomy, periclanoid dissection to cranial tumor, cavernous sinus exploration to dissect and to perform correctly an extradural approach through, for in this case, parasitical triangle to cavernous hemangioverycytoma, for example, or be able in the lab to do transpedrosal approach, as in this case, if we can transform your nice transpedrosal approach, combine pedrosal in the lab in one, in a patient, for example, for a petroclival meningioma. This is the lab. This is the reason why, when I came back from the fellowship, I decided I tried very hard to create a lab in my place with my dear friends and colleagues defining this paper and to create a fellowship. So far, the most important thing that I think that the lab should give to the fellows and to the trainees is not the idea and the goal of publication of another paper of some particular approach that maybe can be less used, but to give them an idea of all the anatomy, curriculum of anatomy, starting from the orbit, going back extradural to the neck, and then opening the dura, exploring everything inside. So this is my message, and I will thank you for the opportunity to talk at this meeting. Thank you.